I think we can get started. I think some folks may continue to dial in, though that's my intro, but it's not main event. So I'd like to thank you all for joining what is the first of what we hope will be a rich series of webinars in our Southern California Regional Dissemination Implementation Improvement Science Initiative. We skipped a number of months after the winter break. We're back on track, and to make up for the reduced number of webinars, we have two speakers today, of whom are associated with the Gehr Family Center for Health System Science, what was originally the Gehr Family Center for Implementation Science, talking about re-engineering visits in primary care. I'll allow each of the speakers to introduce yourselves as you take turns in the tech team approach, but thanks again for agreeing to speak.
Great so much, Dr. Mittman. Good afternoon, everyone. I'm very excited to present our research on re-engineering visits, known as the REV Project in primary care, implementing strategies to reduce readmissions. My name's Albert Elias. I'm assistant professor in the Department of Preventive Medicine at Keck School of Medicine at USC, and also faculty of Gehr Family Center for Health System Science. I will present the project this afternoon with my colleagues, Dr. Michael Hochman, who's director of the Gehr Center, and Sonali Saluja, who's assistant professor and a hospitalist at USC County Hospital. This project is conducted in collaboration with the John Snow Institute, JSI, in Boston, with a grant from the Agency for Healthcare Research and Quality. Next slide, please. As I mentioned, this project is funded by AHRQ, and we have no conflicts of interest to report. Next slide. To discuss the project background and the impetus for our research project, we will then review the study objectives and study questions, and then present on 3 of the research activities that we're conducting here in Los Angeles. The first is an environmental scan that Dr. Luja will present. The second are patient interviews, which Dr. Mike Hochman will present, and I will present on the study of the primary care practice workflow. We'll conclude with a summary of our preliminary research findings and next steps, and there will be time at the end of the presentation for questions, but please feel free to interject if you have any questions along the way. Please. So surprised that there are high rates of hospital readmissions and vary by region and also hospital type and practice. Readmissions are a major patient safety problem, which are associated with medical errors such as medication prescribing errors and misdiagnosis of conditions in the hospital and ambulatory care settings. Since the passage of the ACA, there's been an emphasis on payer and provider efforts to reduce readmissions. National programs have informed or guided been by evidence-based toolkits and guides such as AHRQ RED, which is the Re-Engineered Discharge Project, the STAR program, which is the State Action on Avoidable Readmissions, and Project Boost, which is a project on better outcomes by optimizing safe transitions. All of these have largely focused on enhancing practice occurring within the hospital setting, in the discharge process and handoffs to receiving providers or settings of care. While many of these guides have recognized the critical role of primary care in managing care transitions, they have not been explicit in focusing on enhancing primary care with the aim of reducing avoidable readmissions. Based guidance for primary care settings to reduce readmissions and improve patient safety are comparatively lacking, and this gap in the literature is becoming more pronounced as primary care is increasingly being called to serve as a key integrator role across health systems as part of payment delivery system reform. And this is evident with the patient-centered medical home, where the central role is with the primary care providers. Next, please. The research project aims to address important and unfulfilled need to improve patient safety and reduce avoidable readmissions within the context of primary care. This 2.5-year project utilizes a combination of formative qualitative research and quality improvement techniques in order to understand the barriers and challenges to redesigning the primary care process as it relates to connecting recently discharged patients into primary care, to emerging best practices, and to analyze the workflow process across a diverse range of primary care practices, to ultimately identify components that AHRQ should consider in the development, testing, and implementation of re-engineered visit for primary care. Please. The team is led by the John Snow Institute and includes research in a diverse group of primary care sites. The project team has partnered with 3 primary care organizations, which include the Cambridge Health Alliance in Massachusetts, Kaiser Permanente in Colorado, and with Dr. Mike Hockman, Sonali, and I with the Ultimed Health Services here in California. The project team is conducting the analysis of the primary care processes in 2 primary care practices in each of these organizations, as well as an IPA site in each of these geographic areas for a total of 9 sites. The recruitment and analysis of these primary care sites will be led by the primary care physicians for each of these project teams, and I'll go through what that means in a second. Next, please. Here are the project activities, and there are 4 main activities for this project. First the first projects that we did was we conducted formative research, foundational research consisting of an environmental scan and also key informant interviews to understand and synthesize what is already known from the literature about the barriers to improve care coordination and strategies being used and evaluated to enhance primary care based on these transition strategies. Activities are focused around field research, so to conduct an analysis of the primary care processes and to identify components that we are currently mapping at 9 different primary care sites. Our project team will produce a final report and a presentation of the results and a manuscript for submission to peer-reviewed journals. Each of these tasks contributes to our understanding of the key components that should be included in the REV project to reduce hospital readmissions. Next, please. 2, we will focus on the results of 3 research activities and focus our preliminary findings here from what we've learned in Los Angeles at Ultimed. I would like to turn it over now to my colleague, Dr. Saluja, who will present the first research activities on the environmental scan.
So I'm going to talk about the first activity, the environmental scan, as Albert said. So there's a lot of literature out there about hospital-based interventions to readmissions. However, the purpose of this scan was to summarize the major challenges and potential solutions. So you do next slide, please, Ibrima. To summarize the challenges and solutions related to readmissions from the primary care perspective. For this scan, we examined the peer-reviewed literature using PubMed, Ovid, and CINAHL, which is an index for nursing and allied health literature. And we looked at the terms primary care and patient-centered medical home in combination with the terms readmission, care transition, and hospital discharge. We excluded duplicates, international or pediatric-focused articles, and other non-primary care-focused articles or opinion articles. And also looked at the gray literature for case studies and experiential knowledge from AHRQ, HHS, and other initiatives on primary care and readmission. A total of 535 articles that resulted from our search found 42 peer-reviewed articles that met our inclusion criteria and 15 articles in the gray literature that met our inclusion criteria. Slide, please. Out of the peer-reviewed articles, 14 of them focused on describing the barriers to effective care transitions from the hospital to primary care setting. And so this table describes the barriers that we ultimately divided into 4 categories. The majority of the papers all describe, or most of the papers describe systemic barriers, such as lack of financial incentives for care coordination or other regulatory barriers to information sharing. And these studies noted organizational barriers, such as an inability for EHRs to communicate. There were also provider-level barriers, so the lack of time or competing priorities for prioritizing care transitions. And then lastly, there were patient-level barriers that were described, such as poor support for non-medical needs. Next slide. Right?
This is on. You see the next slide?
Okay, now I can.
Okay.
So this slide is a summary table of the interventions that we found in the literature. And the literature included studies on individual care coordination interventions and also bundled interventions. So the individual interventions included things like automated alerts when patients were hospitalized, the identification of post-discharge complications, such as a clinic-initiated phone call to check in on a patient, medication management, such as medication reconciliation by a nurse or pharmacist after discharge. So these individual level interventions from the literature that we gathered looked less promising in terms of reduced readmissions, so they might have had some other benefits. Bundled interventions are multifaceted and often part of a broader effort, such as primary care medical home transformation. And these interventions could include multiple individual interventions and also often included things like social work or care managers or sometimes even home health. And these bundled interventions were led by health plans, implemented in practices affiliated with hospitals, which was actually the majority of the studies in this category. The interventions were more promising in terms of reducing readmissions than the individual interventions. Next slide. So in summary, we found that the literature on primary care-based readmissions reduction efforts are much less developed compared to hospital-based efforts. We saw that multi-component interventions tended to be more effective than individual interventions, particularly in the context of a more general primary care transformation, like the primary care medical home transformations. Most of the interventions were studied in large academic medical centers, which may not be generalizable to smaller independent practices, so there's kind of a caveat to what we discovered from our scan. We also saw that payer and health plan sponsor transition programs demonstrate the feasibility of implementing programs on a larger scale in a more financially stable way. Next slide. Also have written a perspective piece titled "Primary Care Can Lead the Path to Reducing Readmissions." We discussed the importance of active involvement of primary care providers in the care transition process. Our mental scan is quite lengthy, so this is a more digestible way to disseminate the take-home points from our scan and hopefully encourage people to check out our scan. We also talk about system-wide reforms that will allow for innovation in this area. We discussed improved communication between hospitals and primary care clinics, the need for adequate support and compensation for clinics to lead these transitions efforts, and then also considering incentives and alternative payment strategies to promote innovation. I'll let Mike talk about the second activity, which is our patient interviews.
Upon discharge, And the way we did this is Ultimed is unique as an FQHC in that it's both an IPA, a managed care organization, and an FQHC. And because it's an IPA, it does have claims data, and it knows in real time when its patients are in the hospital, which allows them to, more than many primary care, engage with them while they're hospitalized. And so what we did is we got the inpatient census, identified adult patients, and actually I should say medical students did this, so it was a really good project for them. I should say they actually won an award for the project they did as part of the primary care leadership program. So that was a nice side benefit of getting medical students involved in this. They visited the patients at White Memorial, which is one of the more commonly used hospitals for Ultimed patients. They conducted a pre-hospital interview, pre-discharge while the patient was in the hospital, and then within about 1 to 2 weeks post-discharge did a post-discharge follow-up. They were typically about 10-minute in-person interviews. By phone, the aim was about 10 minutes as well, although those tended to go on a little bit longer. Next slide, please. Here's the result of the pre-discharge interviews. So, and we interviewed 9 patients. 8 of the 9 reported that they did have a PCP and that they knew the name of that PCP, which is good. It's actually probably a lot higher than one might find in other settings. We asked the patient, did your PCP know that you were hospitalized? And 6 of 7 thought the answer was yes. A couple didn't know. 7 of 9 said that they planned to visit their PCP post-discharge, said they didn't know. The majority, 5 out of 6, said they'd like assistance in scheduling an appointment post-discharge. A couple didn't know. And in terms of expectations, 4 of 9 did expect that the PCP to know what happened to them in the hospital, and 5 out of 9 didn't know whether or not that was a reasonable expectation or not. And then I thought this was impressive. 3 out of 9 got a phone call from their PCP's office while they were hospitalized. This is, in most cases, the case manager who does a check-in call to many patients, particularly the higher risk ones while they're in the hospital. Did get that call. Appreciated getting that check-in call. Next slide, please. Here's the post-discharge interviews. Again, somewhere between a week to 2 post-discharge. A little bit less impressive. Since you've left the hospital, have you received any care or support to assist you with any of your non-medical needs, such as transportation, housing, or nutrition? None of them had. Since you left the hospital, have you received any care or support to help you better manage your condition, phone calls, home visits, medication management? A couple had, and I think in many cases this was probably a case manager making a phone call to check in because, again, for the higher risk patients, that's part of the Ultimed discharge protocol. Did you receive any care, support, or referrals from your primary care clinic? Only 1 out of 9 had, and that was a large part a reflection of the fact that many of them had actually not made it in for a post-discharge follow-up appointment. And looking back, was there anything the primary care clinic could have done to have helped you avoid your recent trip to the hospital? I had some ideas, but the most thought that the primary care doctor couldn't have done as much to prevent that initial visit. But not listed here, they also had some ideas on how to prevent readmissions, which is the primary purpose of our study here, and that a lot had to do with post-discharge follow-up care. And if you could just advance one more, Ibrahima. So this on follow-up appointments. Before in the previous slide, only 1 out of the 9 had actually made it into the clinic for a post-discharge appointment. 7 out of 9 wanted it. 5 out of 9 wanted assistance with that post-discharge appointment. So we did present the findings to the Ultimed leadership, and they were surprised. They thought, their target is to get all patients in ideally within 7 days post-discharge for an appointment, and that in many cases hadn't actually happened. I think this is probably consistent with the way it works in real-world settings, not just at Ultimed. We just to make a point of doing patient interviews for a project like this, I think if we had just asked the Ultimed staff, the Ultimed leadership, they would have told us, in fact, they did tell us that patients were getting very methodical post-discharge care, and yet the patients, of course, tell us something different, which is all enlightening. Okay, so I'll turn it back over to Albert.
Sorry. So the third research activity are primary care site interviews and site visits, and so these are currently ongoing, and we're in our second round of interviews now. But the goal of the primary care site interviews was to speak with all clinic staff at the clinics in order to identify their roles in identifying, scheduling, and providing care for patients recently discharged from the hospital. So November and December of 2017, we interviewed primary care staff at 2 Ultimed primary care sites in Pico Rivera and Del Monte, in addition to one of Ultimed's IPA sites that's associated with White Memorial Hospital. We identified that in addition to the physicians, the front office staff, and LVNs and MAs, or the back office staff, patients were also contacted by care gap coordinators, and hospital discharge summaries were coordinated by the Health Information Management Team, or what they called the HIM team. So the care gap coordinators at Ultimed are primarily responsible for filling the gap in care for patients by making appointments to specialists and by also scripting the schedule a few days in advance to anticipate follow-up visits from patients recently discharged to ensure that the discharge summaries are available. Oftentimes, the care gap coordinators will send a task to the Health Information Management Team to send release forms to the hospitals. The Information Management Team was primarily responsible for sending out initial requests to the hospitals for scheduled patients by faxing and potentially following up with the hospitals to ensure that discharge information was available for physicians to view prior to or at the time of visit. I'll go over these challenges and potential opportunities in the next few slides. The other thing that we also identified was that Ultimed has a group of centralized staff, and it's sort of a hybrid hybrid model where case managers are centralized, and sometimes they'll do a few days at the clinics. But there's also pharmacy technicians and pharmacists who also play a role in this transition process. Next slide, please. So the process for the primary care site interviews are shown here. So during the first round of data collection, we met with a group of 3 to 4 staff members from each of the roles that I just went over. So for instance, we interviewed a group of 3 to 4 front office staff for about 30 minutes, and then we met with a group of 2 to 3 physicians for 30 minutes until we had interviewed a group representing every staff role at the clinic. The interviews were recorded, transcribed, and analyzed based on a set of care phases, which I'll review in the next slide. But this is during the first round of interviews. So we are now at step 3, the collection for the second round interviews. So in February of this year, we went back for a second round to confirm the information that we learned from the first round of interviews and to ask any follow-up questions. The interviews were conducted in a similar manner as the first set of interviews, and we're currently in the process of conducting the second round with the central staff, the case managers and pharmacists, and also a second round with the IPA site. Next slide.
Yeah, it's on the next slide.
I think there's a little bit of a delay. Thank you. So the purpose of the preliminary interviews was to engage staff from the primary care site to describe what workflow might look like in order to set a foundation for workflow at 4 care processes. So we asked staff to think about their roles during each of these 4 phases. So the first phase was when the patient is in the hospital. So we asked every staff role to identify what their role was when the patient was in the hospital, after the discharge but before the follow-up visit at the clinic, during the follow-up visit, and also after the follow-up visit. Next slide. So present are the findings from our preliminary interviews, the 2 Ultimate sites and also the IPA site. So we found that there was significant variation in the transition care workflow that was dependent on the patient type and the individual staff members. So for instance, patients could belong to a specific high-risk group, which requires complex care management as identified by the case managers. So each of these patient groups require different transitional care services, and in some instances have a case manager schedule visits for them with a follow-up primary care visit in advance of the hospital discharge. And staff in the same role, such as the front office staff or the care gap coordinators, may not do all the same things or may do them very differently. So for instance, when the care gap coordinators were scrubbing the schedules 2 days in advance of the follow-up visits for recently discharged patients, some of them would actually follow up directly with the hospital to request discharge information, while other care gap coordinators would send a second task or notice to the health information management team, who would then also follow up with the hospitals to the discharge summaries. So many challenges in delivering transition care or care that occurred before the primary care visit, or transitions that occurred before the primary care visit. So really, did the staff know when a patient was discharged? So for certain patients assigned to Ultimed, there is a daily list or registry circulated via email to providers of hospitalized patients, but this was rarely utilized to proactively schedule follow-up visits. So the list was not necessarily clinic site-specific or provider-specific. And the clinics were not proactively reaching patients between discharge and the primary care visit. Potentially, the most significant issue is highlighted here in red, and it was the availability of discharge summaries during the follow-up visits. So it's varied also by the discharging hospital. For instance, in the best-case scenario, some clinic staff have direct access to the electronic health records from one hospital, ranging from, on the other hand, some hospitals would require patients to send a signed release form directly to the hospital, and the hospitals will mail the discharge summaries, or the request for the discharge information had to be in person by the patient. So not having the discharge information was difficult because providers could not properly see what medications were prescribed at the time of the hospitalization, so this was an issue for medication reconciliation. It's hard for the providers to see what tests were ordered, the results of the test, and in some cases, the providers could not elicit from the patient the primary reason for the hospital visit. And so you can see quickly that this follow-up visit wasn't always effective because the providers didn't have all of the information that they needed at the time of the follow-up visit. Next. Seems like there are many barriers. There were also several opportunities that could potentially be evaluated further for redesigning a primary care visit to reduce hospital readmissions. The first was that most, if not all, staff members identified that the goal of Ultimed was to aim to have a discharge follow-up visit within 3 to 5 days. Every staff member that we interviewed identified that this was the goal. To aid with this, the front office staff were able to double book visits with the patient's primary care provider. And they also had a few open slots that could be filled to get patients in faster. However, working against this was the fact that the discharge patient summaries might not be available at the time of visit if it was the next day or even 2 days out. So, mentioned in the last slide, staff members may have access to hospital records, but this was rare and not always the case. So there's a potential to have this process enhanced. There was some coordination to get access to discharge information where the front office staff would notify the health information management team upon scheduling a follow-up visit, and this would allow the HIM team to make the request early on. And they would also, the front office staff would also inform the patient to bring any discharge paperwork in at the time of the visit if possible. However, patients often brought in care instructions and not necessarily discharge summaries. The health information management team would also be notified again when the care gap coordinator scrubbed the chart. However, the health information management team could only follow up and send a second notice to the hospitals. Some were sent over more quickly than others. So even though there was this coordination within the clinic to get the discharge summaries as soon as possible, the time, most of the time was with whether or not the hospitals would send over the information quickly or not. So Ultimed case managers also played an important role in scheduling follow-up appointments and gathering discharge information. So the majority of the tasks for high-risk patients based on their LACE score or provider recommendations were for Ultimed's panel of patients. Since from other health insurance products such as Medicare fee-for-service patients do not have access to case management from Ultimed's case managers. Next, please. So findings from the primary care site workflow that I just shared with you represent one type of primary care health system. And you could see there on the bottom in Los Angeles, we're at Albany and Pico Rivera Ultimed and another Ultimed IPA site. So our results will be combined with those from 6 other primary care sites to develop a set of components that could be further evaluated for AHRQ's re-engineering visits model to reduce hospital readmissions. And those interviews are currently being conducted at primary care sites in Boston and also at Denver in a variety of systems, including Kaiser Permanente, who's more vertically integrated and may not have identified a challenge with getting discharge summaries for their patients in primary care. To hand it over to Sonali, who will conclude with the summary of the preliminary findings and next steps.
Thanks. So from the environmental scan, one of the things that we learned was that multi-component interventions really tended to be more successful. That was especially noticeable in the context of broader practice transformation. I also felt that improved communication and alignment between hospitals and primary care providers would lead to better innovation in terms of transitions of care. Also, providing adequate support and compensation for primary care to play an active role, and fostering effective community partnerships could also benefit care transitions. And from the patient interviews, we learned that a lot of patients in the inpatient setting actually have PCPs, they even know their names, and they do plan to visit them after discharge, but many of them would like more assistance with setting up the follow-up appointments and also expect their PCP to know what happened to them in the hospital. Then also from the primary care site interviews, we learned that challenges in delivering transitional care often occur prior to the hospital follow-up visit. And from those site interviews, we've some new insights, but also many of the providers and staff there corroborated a lot of the barriers that we found in the literature review from the environmental scan. Next. So for next, we still have some project activities remaining. First, we plan to continue our fieldwork at the primary care sites, and they're also meeting regularly to share what we've learned. We have phone calls where we share what we've learned from our site interviews and get feedback from each other, which is always helpful. And we will actually be meeting in person soon to analyze the REV components, and that we hope to disseminate our findings in the form of manuscripts, reports, and presentations to stakeholders. Next slide. Set it up for questions at this point and any feedback from the audience. If you could advance to one more slide. And then have a list of some questions here that might prompt discussion. And I'll leave this up as our last slide.
All right. So there's a very question that got in the chat from Norma. Are you able to see it on your end, Albert and Sonali? Or,
See do I need to change the view? I don't see a discussion.
I'll read it for you. So,
yeah, here it is.
Oh, okay.
Sorry. Yeah. Oh. Chat open. I'm sorry if people were asking questions.
Yeah, I had it open, so I was able to. I think they just able to see the slide. They just were not clicking on the right area. But, I think the first question we got for the Q&A is from Norma. It's the last one. The last one.
Oh, okay. Question from Norma is how many or what % of homeless or long-term care facilities were included? So I assume this is for, the question is about the patient interviews. And I can let Mike comment, but I don't think we included any long-term care facilities. And I'm not sure how many patients were homeless that we interviewed at White Memorial.
Yeah, you know, we all. Oh, go ahead.
Go ahead, Albert. You go ahead.
I'm going to answer from the care site interviews that getting a hold of patients and following up with patients to schedule interviews was identified as a barrier. And some of the staff did identify that it, particularly for homeless patients that are assigned to them.
Yep, to answer the question, the 9 patients who were interviewed were all at White Memorial, so no other facilities besides White Memorial. That's the most prevalent hospital where alt-med patients are admitted. I do remember that one of the 9 was a homeless patient. That patient they were not able to get in touch with post-discharge, probably, you know, for phone access issues. So, you know, but I think you raise a good point that that's a really important population to capture because they're some of the highest utilizers of healthcare services.
Can you talk a little bit about the other phase of our interviews with community organizations?
Sure. And the final piece that we didn't touch on because we haven't gotten to it yet. We're also going to do interviews, or not we, but the JSI team is going to do interviews with community entities that interface with the health system. So, for example, housing programs, community programs that deal with food insecurity and other social determinants of health. Many of these services are built in at Ultimed, particularly for the geriatric population, because they have a PACE program for all-inclusive care for the elderly, which provides meals, transportation services. I think the participants in the PACE program get 14 meals a week. And also, the housing resources is going to be through community agencies in the county, because Ultimed doesn't have any program that directly provide housing. So those interviews are going to be forthcoming and should provide feedback on how Ultimed interacts with these community organizations that address these social determinants.
Thank you. Ibrahim, any other questions on chat? I don't see any in my screen.
There's a second part to Norma's question.
Oh, yes.
Is outreach to patients in hospitals and after discharging home billable services. And then if not, I think there's a comment, this may be a barrier and advocacy may be needed. And just for site interviews at Ultimed, we did not feedback that they were actually billing for any of the outreach that they were doing in this in-between period. So that's a good comment and a good question. Though I know that Medicare does reimburse for some care transitions activities, but I don't know, from talking to Ultimed, we don't know that they're actually billing for these activities.
So I have some follow-ups to those points, but other questions from the participants, the attendees?
There is a new one that just got in that box from Jeffrey.
Yes, sir.
I think it's going to be probably like a multiple-part question. So he's asking, did you consider any linkages or interaction with pre-hospital care providers, given that 911 emergency services often as the gatekeeper for a superutilizer population?
Ibrahim, could you repeat that question one more time?
Yeah. So the question is, did you consider any linkages or integration with pre-hospital care providers, given that 911 emergency services serves as the gateway for the utilizer population?
And that would include, I assume, largely patients who don't have an identified PCP, for whom, linked with the mission care provider is difficult, since there may not be one.
Yeah, that's very true, and I think that's really critical to understanding the readmissions problem, especially for these people who are frequently needing health care, because this process is based on primary care perspective. If a patient identify a clinic or vice versa, then you weren't really able to identify those patients, and so are missing out on that group of patients for this project, I guess. We talked to the sites, and they did mention that, a lot of them are now using urgent care and trying to prevent ED utilization, having urgent cares and after-hours appointments available for patients.
I think in general, so the other part of your question, Jeffrey, about the community paramedicine mobile health program, that is a separate population for which this project isn't directly relevant.
All right.
Yeah, that's right, Brian. At Ultimed, where everyone's impaneled, primary care provider through Ultimed.
So while we wait for others, could I ask for you to talk a little bit more about the other parts of the project team and, in the literature review and the question of heterogeneity and how all of this could come together. So when we think about the status sort of problem in the multiple health systems and the multiple kinds of innovative arrangements that have been put in place, it's always clear to me that, we have one group that's pushing its own version of a, highly manualized model that in fact be highly effective in the sites in which it was studied. May have, less transferability to other kinds of sites, but there might be cross-cutting generalizable lessons out of all of this. And, the distinction that's made with complex interventions between core functions and forms may apply, where there are some, consistent functions that need to be carried out in any transitions reduction program. How do you carry them out or operationalize them very significantly? Is that the thinking of the overall project, and are you planning to provide that kind of general, highly adaptable guidance and findings?
So comment a little bit about the sun, and so, yeah, you're absolutely right that a lot of the interventions were in academic primary care that were affiliated with that large academic hospitals and had a lot higher levels of resources than small independent clinics. There was, I think, one study we saw done in a small independent clinic on a bundled intervention. The one they thought about was that, and this is something that I think is worth studying, is if small clinics were to kind of band their resources together to potentially hire social workers or care managers to help them with the transitions care process. So that's something that we've heard anecdotally, but we didn't necessarily see in the literature. And then another point that we kind of discovered was that smaller independent clinics actually tend to have pretty good outcomes when it comes to readmissions. And we interviewed one of the IPA sites that was basically a one-physician site, and they had a very close relationship with the with the hospital that was next door where most of their patients went. They're actually very adaptable, very nimble. They worked really well as a team together. So they have very different advantages that might actually serve to help them with readmission.
We are actually meeting with the team in Boston in June to really get at these cross-cutting, generalized components that may be necessary to reduce hospital admissions within the primary care setting. And, I think that when we had talked a few weeks ago, there was this idea about, well, let's identify the best practices within each of the sites. And, that doesn't always work because we're not necessarily measuring outcomes on any of these things, but all we could do is identify the components that were necessary or some of the barriers and facilitators within each of our sites. And so coming together and producing a report on these cross-cutting interventions that are necessary regardless of the strengths that could be highly adaptable to each of the different small IPA sites and some of the more coordinated places like Kaiser may be able to take a model and apply it to their setting.
Sure. I encourage you to think about the form-function distinction as one way of trying to pool across the different projects and about the communication function, the different ways it's carried out. It sounds like with that one, the back office staff may know each other, or they have lunch together, or physicians work closely, and that's how they are so effective in communicating. And as you said, we have shared medical records. Norma's question about billable hours doesn't apply to capitated systems. So, thinking about and presenting this in a way that does allow any type of site to, for example, select from a menu of different firms or methods to carry out each of the core functions would, I think, be a useful way to, take advantage of the richness and the variety that you have in your sample.
great.
Mm-hmm.
Other comments from other participants?
We don't have any new questions in the chat box for now.
You're taking them verbally.
Yes.
Yes.
You're on the line.
It's Jeff
Mics
Gooder.
are open.
I thought I heard, but I may have misheard, that there were a group of Medicare fee-for-service patients who did not have care managers assigned to them. Did I hear that correctly?
Yeah, so we still need to go back and do a second round of interviews with the case managers, and maybe Mike can speak to this a little bit more. But so Ultimed, it's my understanding that Ultimed has their own panel of patients where they provide case managers for Ultimed case managers. But also see patients, or patients could be assigned to a primary care provider from other health insurance plans. So, for instance, someone on Medicare fee-for-service may be seen at some of these clinics, and they don't necessarily have access to case managers from Ultimed directly. Mike, do you want to talk a little bit more about that relationship?
Sure. So, Jeff, you hit on a really important point. Ultimed, 80% of its population is managed care, Medicaid, and those are the ones that they track through, managed care, IT systems, as a case manager, do targeted outreach. But they have a smattering of a little bit of Medicare fee-for-service, a little bit of commercial, some uninsured, and those patients are a lot harder to track because they're not, technically impaneled. And Ultimed has tried as best it can to implement a payer-agnostic approach in which they manage and provide the same level of support services to all its patients. But see, they're not going to get notified when a Medicare fee-for-service patient is admitted to the hospital unless and until there's some sort of a functioning health information exchange throughout the county, or at least an ADT alert system.
In Los Angeles County, there's been a shift towards more managed care, so I'm not sure what percentage of patients are actually on fee-for-service still in Medicare. Oh, still 20%.
Or even less, maybe, yeah.
Thank you.
Right. Thank you for production and the answer. Any other questions, either verbally on the phone or in the chat box? Just feel free.
Or any additional thoughts or comments or requests from the three presenters as to anything you'd like to know from those on the line, representing different systems?
Well, I'd be curious, the hospitals have traditionally led the care transitions process, and JSI got this grant to sort of ask the question, do primary care clinics have a role? And then that raises the question, do they both have a role? And if so, who should they be talking and communicating? I guess it'd be helpful to sort of get people's thoughts. Is it useful to draw that distinction between primary care-led versus hospital-led versus jointly-led initiatives? And it is, but it just depends on the system, which makes more sense.
I would be interested in knowing as well, within Kaiser and the large Macquarie program were involved in, primarily hospital-led, organized, although, obviously in Kaiser it's both, it's system-led, but, that's the neat feature of what you were doing, and, very eager to see, how the findings relate to the bulk of the work that comes from, hospital-led initiatives. Again, that relates to this issue of, so many different kinds of systems and, fiscal and administrative organizational arrangements.
This is Heather from Kaiser. Hi, Brian. And just wanted to chime in that I definitely agree that the primary care setting and ambulatory care overall has a main role in preventing readmissions, and the transitional care that is provided by those groups include care management and the primary care or specialist follow-up visit is key to reducing admissions. We actually published a study on the impact of the follow-up visit within 7 days on readmissions, and it was significant and probably included in your evidence review that you mentioned earlier, but I would definitely agree with that. And some of the ways that we have been able to help improve quality and the effectiveness of the primary care visit is by, standardizing the discharge summary format, so the key information is at the top and providers can easily refer to it and when they have a patient coming in for those follow-up visits. I know that's easier for us to do because we control the electronic medical record, but maybe something that could also be worked on with other systems.
So in Maine, is there a standard, I'll call it the hospital inpatient CCD, so that we're not relying upon people dictating stuff that others may or may not care about? Is there a CCD-like standard for, here's the important stuff that happened during this hospitalization? So it would have the reason for admission, discharge, diagnosis, med recon at discharge, and some other key things, so that you didn't have to wait for anybody to dictate anything. It was available like a CCD-4 is for ambulatory.
I don't think so, Jeff. As far as I'm aware, there's not even an ADT alert system in LA through CARE for, certainly not for the fee-for-service population. All gets notified for if you're getting at the discharge summary. You're aware of Ultimate accepting C-formatted information on hospital discharge. Are you aware of hospitals that are sending that out?
I didn't think of it until this call, but I'm thinking, your biggest barrier, which I think which resonates with, I would imagine, everyone on the call, is the time delay from discharge to discharge summary. Yet the elements that are really important for that first follow-up visit, being to put together.
Right. And when we're talking about the health information management team at these sites getting documents from the hospital, sometimes the documents would be 100 pages or so with the actual scans and results, and
right. And
they had to scan everything into their records so that the providers could see the information. But you're right. And then what is given to the actual patient, a lot of it was get a little more exercise and eat a healthy diet, and they were giving that to their provider as well, and that was more the patient information rather than the actual discharge summary of what was done.
Yeah, and we saw was that providers weren't getting a discharge summary, and this was particularly problematic from certain hospitals. They were able to name the hospitals, and they actually said that sometimes patients would have to go in person to the hospital, to the medical records, because the hospital would only mail their discharge summaries. That's the only way they would communicate with the hospital clinics.
All right. So we are almost at the hour. Any last question, comment from the presenters or participants who are on the line?
So let me, this is Brian, let me add my thanks again for such a nice presentation, and just a reminder, every one of our one-day symposium coming up the end of June. If you haven't registered, please do so, and we'll look forward to seeing many or most of you there.
All right, thank you, Michael, Albert, and Sonali.
Thank you.
Thank you.
Thank you for attending. Bye. Good day.